We're glad you could join us today for the ECG webcast, Negotiating Now with Health Plans and Payers. I'm Rachel Bigood, a manager at ECG, and I'm pleased to be your moderator for today's session. Even amidst today's many new challenges, it is still important to prioritize your managed care contracting strategy. Your strategy will impact the financial stability of your organization now and into the future. In this webinar, ECG experts will review the new payer negotiation strategies required to succeed in a post-COVID-19 world. We will address specific actions that a provider organization should take to ensure adequate reimbursement for services provided in the new normal. Today's environment presents a unique opportunity to participate in value-based payment models, and we will discuss the rationale for each strategy and outline key considerations for participation. Through ECG's national experience, we will provide guidance on navigating payer negotiations and planning for the future. Before we introduce today's speakers, let's go over a few details about the webinar. Today's program will be 45 minutes in length. There will be 45 minutes of presentation and 10 minutes for questions and answers. Everyone should have received a copy of the session handouts, but if you are a late registrant, you can download the handout in the handout pane on your screen. Attendees are participating in listen-only mode, but if you have questions, you can type them into the questions pane on your screen at any time, and we will address them at the end of the formal program. If we were unable to answer all of the questions today, we will follow up with you after the session. And finally, upon exiting today's program, you'll be directed to an electronic survey. Your feedback is important to us, so please take a minute to complete the survey. For each completed survey, ECG will make a $5 donation to Doctors Without Borders. Our speakers today include Ken Steele, a principal in the San Francisco office who has 30 years of managed care and hospital leadership experience and has helped many hospitals and health systems make substantial improvements to contract reimbursement rates, contract language, and revenue cycle management. Purvi, a senior manager in the Washington, D.C. office, has provided extensive executive-level leadership to physician groups, hospitals, and health systems in the area of payer contracting and strategy across the country. ECG has extensive experience working with hospitals, health systems, medical groups, ambulatory surgery centers, accountable care organizations, and clinically integrated networks in developing and implementing managed care strategies while responding to an increasing emphasis on value-based payments. We have a dedicated group of individuals within our firm who have devoted their healthcare consulting careers to managed care strategy, planning, operations, and contract negotiations. Our Managed Care Services Division bridges the gap between providers and health plans in order to expand coverage networks, as well as develop pricing minimums and targets, quality and performance-based reimbursement strategies, and new payer products. Our ability to understand the issues that are sensitive to both providers and payers gives us a keen perspective on and unique effectiveness in developing cross-institutional clinical and financial arrangements. ECG has strong analytic and modeling capabilities to help guide organizations in their financial and strategic decision-making processes. At this point, I'll turn the program over to Ken.
Thanks, Rachel. Let's start on slide 4, which is the learning objectives. We've outlined 4 learning objectives for you today. So the first one is to review the key payer negotiation strategies. We also want you to understand the financial impact of COVID-19 on hospitals, physicians, and payers. Also, we think there's actions that you can take to ensure your financial optimization of your managed care contracting portfolio. And then we'll also discuss value-based payments, what's happening today and what we see post-COVID-19. So briefly, let me review the agenda on slide 5. I'll do a short introduction. Purvi will cover the COVID-19 financial impact. I'll discuss 5 key elements of your negotiation strategy. Purvi will then talk a little bit more about value-based strategy. We'll have some final thoughts, questions, and discussion. There's also an appendix here titled Operational Considerations for Telehealth. So that is an important part of this presentation. We won't be covering today, but we want to provide you with some content because we know nationally that everybody has stood up telehealth. Now the question is, what does that look like in terms of revenue cycle, coding, payments, payer contracts? So there's some good guidance in that appendix, and there's also a snapshot of where all the commercial payers are in terms of telehealth. So please look at that when you have a moment. So let's talk about the introduction here. Just as a couple reminders on page 7 here. If you look at the right-hand side, this is a time in which healthcare workers are being viewed as heroes because they're risking their lives daily around the fight of COVID-19. So this is an opportunity for you as providers to remind payers of the goodwill. We don't think it's a good opportunity for a payer to be terminating contracts and getting that news out publicly. We think it really is a time which favors you as providers to renegotiate contracts. So on the right-hand side here, you're going to see a quote. We're seeing an outpouring of appreciation and goodwill for healthcare heroes on the front lines against COVID-19, for providing care and compassion in these unprecedented times, for being a light in the face of uncertainty. And I'm sure that many of you have read articles nationally and locally about healthcare workers. Unfortunately, on the left-hand side of this slide here, over 600 healthcare workers have died because of COVID-19. That was in earlier June of this month, and also 9,000 plus healthcare workers have contracted COVID-19. So it is taking a toll on our delivery system. On slide 8, just as a reminder in terms of your managed care contracting process, many of you are doing this. This is what we see as some of the key elements for renegotiating contracts. But the first thing is conducting a reimbursement and benchmark analysis. We do believe in something called parity, where regardless of the national payer, they should be paying you somewhat equivalent rates for hospital and physician services. So that's the parity analysis. Make sure payers are all paying you a fair rate. Look at the market assessment. What are your competitors doing in the market? What are the health plans doing in terms of their premium increases and also profitability? Third is complete a financial analysis, and we're going to talk about capturing costs and the revenue impact of COVID-19 as part of that discussion with the health plans. Review your contract language. Too often we get the rates done and there's not enough time to do the contract language. Contract language is becoming more important because payers are using contract language to do pre-authorizations and denials and audits. So it's important that you make sure that contract language is still at the forefront of your negotiations. And then number 5 is develop a situational assessment. What's your value proposition? What's different about you in the marketplace? What are the services that you deliver that other competitors may not deliver? Develop your strategy, number 6. And number 7, we don't recommend shaking hands right now, but in number 7, we do want you to have favorable agreements and execute those agreements accordingly. So with that, I'm going to turn it over to my colleague, Purvi, who's going to talk about the COVID-19 financial impact.
Thank you. Now, as Ken mentioned, providers around the country have really stepped up in unprecedented ways throughout the COVID-19 pandemic. But the related economic issues have presented significant challenges for all provider types: hospitals, health systems, and medical practices. And despite healthcare providers in many states and localities now being able to reinitiate non-emergent healthcare services, they are by no means out of the water yet. Most healthcare leaders are beginning to shift their focus, however, from preparedness to business recovery after reeling from over $200 billion in losses over the past 4 months, attributed to both loss in revenue as well as increasing costs. Now, in the top right red segment of this graphic on slide 10, we'll start with financial loss. Over $160 billion is attributed to revenue losses as hospitals incurred decreases in emergency services, non-emergency services decreased by 50%, and overall discharges were down by 13% compared to the previous year. And the financial situation has also further been exacerbated by sharp increases in costs that were also incurred by hospitals, primarily in 3 key areas related to treating COVID patients and protecting staff. In the top left turquoise segment, $36 billion has been spent in direct care for COVID-19, such as setting up testing sites, as well as adding bed capacity and capabilities to isolate and treat patients. Now, moving on to the bottom left green segment, we show that $2.2 billion has been spent on providing ancillary support for healthcare workers, not only through medical screening and treatment of COVID-19, but also providing childcare, housing, and transportation for those who need it in order to be able to come to the front lines each day supporting the rest of the community. And then finally, on the bottom right gray segment, we show that to date, hospitals have spent at least $2.4 billion in PPE purchases to protect clinical and non-clinical hospital staff. And as we move on to slide 11, you'll see that the outbreak has also had an overwhelming impact on ambulatory care. Now, according to a recent MGMA study, 97% of medical practices reported having experienced a negative financial impact, directly or indirectly. By April, there was a 68% decline in utilization for healthcare professional services nationally, while some parts of the country even saw utilization decreases as high as 80%. Now, during the same time frame, practices reported a 55% decrease in revenue, oftentimes resulting in furloughs and even layoffs for both clinical and non-clinical staff. And not only is volume and subsequent revenue disappearing, but medical practices are also being faced with increased costs in order to minimize risk to their patients, their employees, and even themselves. Many physicians have reported having to cut their office staffs by at least half, and a small percentage so far have actually had to close their practices either permanently or temporarily. Now, naturally, the majority of practices are extremely concerned about the long-term effects of the pandemic, not only on their practices, but also on the physicians themselves. When you're talking about stress and burnout, this is a non-financial implication that is not yet reflected in many of the statistics that are being reported. Now, on slide 12, we've actually cited a real-life client example that demonstrates some of the actual costs being incurred by a practice to provide safe patient care during COVID-19. Now, you'll see here that the first three items listed on slide 12 represent tools related to implementing telehealth services that many practices have relied upon to help temper some of the volume decreases by providing alternative options for rendering patient care. But these costs aren't insignificant. For small to medium-sized practices, you're still looking at over $100,000 in incremental cost on an annual basis to cover the telehealth platform, electronic document management systems, and text communication applications. And then there's an additional $100,000 that's also been spent by this practice for PPE, which is going to be an ongoing direct cost, as well as one-time costs that were already incurred by the practice just to be able to open their doors again. Now, this is a major burden when we're talking about practices that are already under significant financial duress. And as you turn to slide 13, you'll see that even if the practices are able to keep their doors open, the financial strain isn't likely to diminish anytime soon. Now, even as some areas have lifted restrictions on non-emergent, non-COVID care, volumes are slowly inching back, but patient visits are still expected to stay well below pre-pandemic levels. And we recognize that the impact will certainly vary by specialty, but the threshold that defines full capacity is also lower than historical levels. Practices are now forced to limit scheduling to account for social distancing, and they also have slower turnover in exam rooms to account for more extensive disinfecting procedures. And then also the fear of exposure to the virus in a doctor's office or hospital campus while seeking medical care is also keeping many patients away, unfortunately. Now, even though there's pent-up demand, volumes may not return to normal in the immediate future. And while this will likely result in decreases in income for both independent and employed physicians alike, many independent physicians are more likely now than ever to pursue a partnership or alignment with a larger organization, primarily for financial stability. And we at ECG certainly believe that consolidation in the industry now is inevitable. And then finally on slide 14, we would be amiss if we didn't cover the full spectrum of the healthcare industry and also discuss the impact of COVID-19 on health plans. Studies have shown that health plans are likely to remain profitable despite the uncertainty in this pandemic. In the first quarter of 2020, we saw payers such as United and Humana with revenue growth between 7 to 18%. And decreases in both facility and professional utilization will continue to contribute to further increasing payer profit margins. And according to Moody's Investor Services, even in the most severe scenario, should 40% of Americans be infected by the virus, payers would still likely break even and have notable capital and liquidity. Now, essentially, the decline in medical care for non-COVID conditions has more than offset the impact from COVID-19 claims. We recognize that the impact of COVID now will likely vary by lines of business for the health plans. For example, the job losses that are likely to incur have already started to incur could manifest into enrollment decline for commercial payers. Yet in this scenario, Medicaid plans would be in the strongest position as more people enroll in that type of coverage. But we do understand that the shifting landscape will eventually impact insurers' revenue and profit margins, but it only further reinforces the need for payers and providers to work as partners in the new environment, and the need to help independent providers keep their doors open, as well as the need for innovative value-based payment models. So now in the next section, Ken will talk about key considerations for providers as they enter negotiations with payers.
Thanks, Purvi. Let's go to slide 16 and talk about 5 key strategies that we at ECG have identified for your consideration in this new environment that we are in. So the first blue box on the left is emphasize the financial losses and reduced volume. And Purvi cited statistics earlier that the $2.2 billion operating loss for providers, hospitals, and physicians, $50 billion a month. And a lot of that is because of the revenue drop. So that's going to be accruing to payers, and they are going to continue to be highly profitable. The second item is make sure you highlight the risk of continuing to provide care. We've already cited some of those statistics. Consider value-based payment models. We think there's going to be an acceleration of risk-taking and innovation post-COVID-19. The fourth thing is to ensure telehealth is included in your contracting strategy. We'll talk about that in more detail. And also from a blocking and tackling standpoint, contract language is still going to be important, and there's some things that you can do to protect yourself for the future. So with that, let's talk about emphasizing the financial losses on slide 17. So the first bullet point, whatever you can do to emphasize your losses and your cost increases, the payers need to understand the financial challenges, and hospitals need to seek additional revenue because of what's occurring in terms of the healthcare delivery system losses, impact on your whole business model. And as examples Purvi cited, there's in item number 2 here, there's additional acquisition of PPE, there's safety precautions. Hospitals are not going to be as efficient in delivery of care. I talked to a hospital president last week in California who has semi-private rooms, and those rooms are not semi-private anymore. There are single patients in those rooms because of COVID-19. So capacity in that hospital has dropped drastically, which really makes it more inefficient to serve patients and have them flow throughout the medical center. The fourth thing is make sure you talk about the negative impact and also talk about payer profitability, which Purvi just mentioned. The last thing on this slide I want to talk about, the last bullet point, is even though you're experiencing a revenue decrease, you cannot take for every dollar in revenue that has been decreased a dollar out in cost. Hospitals and physician practices have high fixed costs as part of operating the business. So even though payers may be paying you less, your operating costs on a per unit basis are going to continue to climb. So healthcare is going to become more expensive in this new normal. So let's look at slide 18 and talk about some of the risks. And again, these are conversations that we would recommend you have with payers because they are a bit isolated in terms of what happens on a day-to-day basis. So make sure you're talking about the risks and other complications. Providers are contacting COVID-19. Patient room turnover is decreased because of the disinfectants processes, as an example. We're seeing appointments being canceled in terms of testing and also ambulatory surgery. Telehealth has been a great strategy to allow patients to access their providers. And also emphasize toward the bottom of this slide that you need to be compensated for the additional risk, that your job at the hospital and the physician practice level is to ensure safety. And that comes with new processes and new protocols, cleaning, et cetera. And the question is, what's going to happen to volume here on slide 18? May not return to COVID-19 levels due to additional safety precautions and the fact that hospitals have to take units out of service because of capacity issues. It's going to be a shortage of healthcare workers. We're always seeing that. So make sure that you are talking to the health plans about the risk of providing care. On slide 19, Purvi is going to dive into this a little bit more deeply, but the value-based payment models are important. You need to continue to innovate. We've already seen the shift from inpatient to outpatient. Now we're seeing the shift from outpatient to ambulatory surgery settings. Patients are avoiding hospitals. They view hospitals as being risky in terms of contracting COVID-19. Good news is we're seeing the addition of the telehealth platforms. We're seeing more focus on health and wellness. And moving away, as you know, from volume to value, we'll continue to see that where we're rewarding organizations, hospitals, and physicians for value performance and not so much about volume. You do have monitoring equipment now through telehealth. You'll be able to report out, we believe, key performance metrics. But again, we think that value-based programs will provide an additional reimbursement opportunity if you meet those metrics. Also, hospitals and physicians are looking for revenue streams, which means capitation might be viewed more favorably because you're getting a per member per month on an ongoing basis to take care of a defined population. So let's talk briefly on slide 20 about telehealth. This is a modality that, as you know, has been adopted quite rapidly across the country. Now it's a question of, do you have the right strategy around telehealth, and what do your payer contracts say? And most physician contracts are silent on telehealth because it's relatively new. So we are encouraging clients to proactively negotiate payer contracts for telehealth in order to lock in the rates now. That essentially the payers are paying telehealth as if it's an in-person visit. You need to make sure you lock in those rates because everybody is concerned about what's going to happen, particularly in the fall. If you look at the third bullet point here, nobody knows what's going to happen when they start to proclaim and take a new position. So get out there early if you can and negotiate those contract rates. At the top of the page, you'll see this astounding statistic in the first bullet point. The telehealth claim lines increased a staggering 4,347% nationally from year to year. So it's really incredible what's happened. And thank goodness for telehealth. Many organizations were dabbling in it and deploying it, but now it certainly has accelerated. And then emphasize towards the bottom of this slide the importance of delivering care via telemedicine. It increases access. I'm sure many of you, like me, have access to care now through telehealth. It does reduce the cost of care. It improves the quality. If you're in risk models, capitation, downside shared savings, it's a great opportunity to continue to stay in touch with patients to avoid hospitalization and or unnecessary ER utilization. And it is the first defense now in terms of COVID-19 because you no longer have to have an interaction with a doctor and or a physician and staff. So telehealth is going to continue to grow, but make sure your contracts allow you to be paid at in-person level rates. So on slide 21, language. You know, what we're seeing again, I mentioned this earlier, but a lot of times language is the last thing that gets resolved because payers want to have rate increases first. And generally what we find is that you need to agree to a trend, a rate increase years 1, 2, and 3. And then you start talking about language and there's not enough time because the contract is just terminating. But what we're doing now with clients is we're getting contract language out more quickly to the payers and start that negotiations before you even put a rate proposal on the table. So a couple things here on this slide. The first bullet point is consider adding a force majeure clause that's going to protect your organization from unforeseen circumstances like a pandemic, like a catastrophic event. And also you should have some flexibility that during these times you may not be able to perform certain contractual obligations. And that's bullet point number 2. And then be aware of the APP oversight because physician oversight is important in terms of APPs being able to bill and collect for the services that they're rendering. A lot of contracts aren't clear on APP reimbursement, so make sure that's part of your negotiations. Look at things like waiving authorizations on the next bullet point. And also we know that denials have increased across the country. Payers have gotten more sophisticated with automation of claims payment and claims denial. And it's a struggle, but whatever you can do to improve that language around reducing denials is important. And then whatever, we've also seen, believe it or not, last bullet point, language in contracts that actually lowers payments in the event of a pandemic. So make sure that you don't have any such language in your contracts. So with that, I'm going to turn over to Purvi, who's going to talk about a value-based payment strategy.
Thank you, Ken. So we are on slide 23. Now, we recognize that the COVID-19 crisis has temporarily sidelined the shift to value-based care, but it's creating a strong case for the future. Most recently, about a week ago, CMS actually called for a renewed national commitment to value-based care. And we believe that there are several market dynamics, including the 6 that are listed here on slide 23, that will accelerate this transition or evolution. You'll notice that some of these are marked as new, and we believe that these are actually market pressures that may have existed before, but now being driven by COVID-19 are further accelerating support for value-based payment models. So I'm going to start on the top right side. First, you have a significant shift, as Ken mentioned, inside of care, with many patients preferring to have non-emergent procedures and care conducted outside of the hospital setting or in lower cost settings. And this shift was already occurring prior to COVID. As Ken mentioned, there was a shift from hospital to outpatient, outpatient to ASCs. And now many commercial payers have already been adopting these site-neutral payment policies in order to manage costs, and this shift is now being further supported by, again, the patients seeking to minimize their exposure to the virus by avoiding hospital settings. Now, commercial bundle payments are a great example, actually, of how payers are incorporating or incentivizing physicians to shift procedures to outpatient settings for services such as orthopedic, cardiac, and several other procedural service areas. There's also an aging population that requires focused care management and could benefit from some high-touch programs. As we all know, value-based care really is focused on care management. We also are now starting to see, as we've talked or referred to several times in this presentation, declining utilization across the market, and that really has driven the need for consumer loyalty. And even before the pandemic hit, we were already dealing with a looming national physician shortage. We've started to see creation of multifaceted care teams, more creatively being utilized, are advanced practice practitioners, also ensuring that they're practicing at the top of their license. And all of this is being done to meet demand and maintain access. Now, while digital health or telehealth is not new, the public health emergency has certainly demonstrated its usefulness to telehealth, to improving access to care and to helping reduce the transmission of the virus. Now, in a matter of weeks, most of the barriers, including payment parity for virtual visits, the ability to provide telehealth to patients at home, and even allowing more providers to offer telehealth visits have really come underway. And we understand actually that an upcoming Medicare payment rule will also include proposals outlining plans to permanently expand reimbursement for telehealth services. So digital health adoption and reimbursement has really been launched into a new era, which will help to scale access and help further support some care management strategies. And finally, as I mentioned before, there is strong support from the federal government to transition to alternative payment models. And commercial payers are also likely to follow suit as they too are focused on cost management. So moving on to slide 24. Now, the pandemic has certainly highlighted the need for providers to create alternative revenue sources that aren't tied to visits or volume. And as CMS Administrator Seema Verma stated recently, value-based care can help ensure healthcare resiliency. Now, that said, the appetite for risk, however, will certainly vary from one provider to the next. And on slide 24, we've presented a range of value-based models based on varying risk levels and key market drivers, some of which we just discussed on the previous slide. Now, the key characteristics that are describing each model may overlap with the other models, but for the purposes of today's discussion, we've bucketed them based on key drivers within each model. So I'm going to start on the left-hand side. Success in a shared savings arrangement can be achieved by focusing on shifting care to lower-cost settings, improving efficiency and utilization, and ensuring each provider is working at the top of their license. Again, commercial bundle payment models are probably a great example of shared savings models where providers are incentivized to transition care to lower cost settings and then share in those savings with payers. Now, some bundle payment programs, though, may involve downside risk, and they would fall into the shared risk category. So under shared risk, providers are incentivized to manage chronic conditions for a targeted population. Minimizing risk is important. Minimizing leakage is important in shared risk models, and if excess cost of care is actually driven by readmissions, especially if excess cost of care is driven by readmissions or emergency services. So remote patient monitoring can enable providers to manage and navigate care for these patients, and if managed within your own network, it can really help you to prevent unnecessary admissions. Now, examples here might include the MSSP program for Medicare or ACOs for commercial populations. And finally, in a capitation model, providers are at financial risk based on whether the total cost of care exceeds the sum of the per member per month payments. It offers a stable, predictable source of funds that may protect against volume variability, such as what's happening today, and allow providers to truly focus on care management. Now, we've spoken, as Ken mentioned, we've spoken to many of our clients who have already been part of capitation arrangements pre-COVID, and found that many were really grateful for the consistent cash flow to at least help them stay afloat in the short term. Now, in the longer term, we know that monitoring utilization will still be critical. In fact, many of the capitated contracts are obviously predicated on managing risk, which is tough when you have patients that are avoiding the doctor's office and perhaps delaying necessary care, which could result in them becoming sicker and costlier to treat. We do see, though, that payers, including CMS, want these models to succeed for providers, and they are constantly making updates to make sure providers are not negatively impacted, but yet incentivized enough to drive change. Now, nonetheless, providers should be mindful that, like with any fee-for-service agreement, to ensure that contract provisions are appropriate and so that they don't create undue or unnecessary administrative burdens. So you really should really focus on some of the key contract provisions as well. So, for example, they should carefully calculate targets and benchmarks and ensure baseline measures are appropriate. They should also implement downside risk parameters such as stop-loss limits, risk corridors, and appropriate exclusion criteria. And finally, providers should start to have conversations with payer partners regarding how they can help them support digital health strategies. So moving on to slide 25, we've mentioned how COVID-19 has truly been a catalyst for accelerating digital or telehealth service. So we wanted to emphasize how a digital health strategy can optimize performance in some of the various risk-based arrangements. Now, each payment model presented on this slide presents its own set of challenges or key infrastructure requirements that are needed to operationalize key components of each model and truly drive success. So we believe that digital health tools and strategies can be applied in varying capacities and really help support providers in overcoming these challenges. We can start with shared savings as the first example on the left. Care management, as we mentioned before, care management across the continuum of care is key. So providers can use or utilize telehealth and remote patient monitoring to track clinical status and outcomes across this continuum. And then shared risk models can also be supported by the development of referral and case management tools. And there are certainly digital health applications out there that provide navigation services and home health patient monitoring that would be essential for managing spend. And then in capitation models, providers can use telehealth and other applications that provide data and analytics so that providers can target those patients that are at risk, highest at risk, and they can deploy case managers to meet some of the clinical and even non-clinical needs of patients when access to office visits or in-person visits are limited. So digital health applications can, again, sort of provide a variety of needs, but in the capitation arrangements, they can also be used to support interoperable care delivery platforms to manage total cost of care arrangements, so where you have providers that are at risk for spend beyond their four walls. So you can see that as you're developing your payer strategy, it is going to be critical However, to ensure that it aligns with your digital health capabilities and infrastructure, just as you would want it to align with your clinical care models. And we recognize that even though the capabilities may exist, it certainly could be a daunting task to stop and think about aligning your payer and digital health strategies. Over the past several months, many organizations have really rushed to set up telehealth capabilities to meet various service demands, oftentimes on an as-needed basis. But recently, they found themselves able to pause and reassess, and they've realized that they might actually not have a cohesive and coordinated structure in place that would allow them to optimize these types of value-based arrangements. We truly believe that having a well-thought-out digital health strategy can truly help providers bolster their ability to ensure access, to coordinate care, and to build customer loyalty. And with that, we will transition back to Ken, who will provide us with some closing thoughts on optimizing your payer discussions and negotiations.
Thanks, Purvi. Let's go to slide 27. So one of the questions we always get at ECG is what should we be expecting in terms of target reimbursement? So we want to give you some guidance. We do believe now is the time to be aggressive around payer negotiations and increasing your contract rates, even if you're already in a contract cycle, and we'll also give an example of that. But we do know that rates vary by market, by specialty, and by product, so this is kind of a high-level national view. So let's start with physician rates. In terms of percentage of Medicare on the commercial side, we have a range here to begin with of 140 to 160. That's kind of a normal or typical range. These are for medical groups. If you're an individual doctor and you have a PPO arrangement, with a health plan, a lot of times those rates are 100 to 105% of Medicare. So when health plans contract with doctors individually, we do see rates around 100% of Medicare for commercial patients. So this is more of a group view. If you have a good market presence on the physician side, we typically see rates in the 160 to 180 range. And that means you've got multiple locations of primary care and specialists. You've got good geographical coverage. But where you really need to be at is the 200 to 260%. That's where we like to see groups in terms of commercial reimbursement with the major payers. If you look at a spend, a hospital spend versus a physician spend with a major payer, typically 85% of the spend is going to be at the hospital level, and 15% is going to be at the physician level. So even though you're requesting aggressive rate increases on the physicians to get to 200 to 260%, the dollar impact is going to be small on the health plan, so kind of keep that in mind. We do see in select markets the 300% plus of Medicare for commercial payments. That's typically an academic medical center, and we also see that in children's hospitals with key specialties like cardiology and neurosurgery as an example. So some guidance for you on physician rates in terms of what you should expect. Let's talk about hospital rates here on the right side of the page here. So we at ECG believe that regardless of the mix of services from a commercial payer, you should be achieving a 45% profit margin. So regardless of how much ER volume there is, ambulatory surgery volume, what your stop loss cases look like, or the language, you need to achieve a 45% profitability. Now, you can also look at what are payers yielding in terms of per diem rates, what are you yielding in terms of discharges per discharge rates. You can look at it on a DRG basis. There's all kinds of ways to look at commercial payers. And we do believe in something called parity, which is regardless of the payer, whether it's on the hospital side or physician side, you need to have those payers paying you within a very small margin. We don't want you to give, or we don't think it's necessary to give any particular payer a pricing advantage in the marketplace. So achieve parity within your portfolios, and we believe the best metric is 45% profit margin on commercial business. Now, why do you need a profit margin? 45% may seem aggressive to you, but Medicare is not paying you for not achieving a profit margin on Medicare. Usually Medicare covers variable costs and part of your fixed costs, but you're not generating a margin. For Medicaid, most organizations, you're getting paid variable costs. They're not contributing all the fixed costs or a margin. And the payers know that they are subsidizing government payers. That's just the way the system works. So you need to achieve a 45% profit margin on your commercial payer business. In terms of annual increases, we're seeing typically 3 to 5% is where most organizations are ending in terms of in terms of trends on annual increases. We do know with payer negotiations, a lot of time they're going to give you a zero rate offer out of the gate. We send that back to the payer and say we're not going to negotiate against ourselves. When you give us a rate increase, we'll start to negotiate. If they don't give you 0%, they typically start at 2%. That being said, we have clients that are at 7%, 6%, and 5%, 7% year one, 6% year two, and 5% year three. And the example here that we're giving in hospital rates is we're seeing a downward trend. Most payers want to have a descending trend in terms of the rate increases because they want to go to the employers and say healthcare costs are going to be decreasing because we have multi-year agreements with physicians and hospitals, and that trend is decreasing. But we do believe that you can get more in the 7%, 6%, and 5% range based upon what we're presenting today. So with that, let's go on and talk about kind of a managed care planning on slide 28. So this is a client example. If you don't have a calendar in terms of what's in your queue to negotiate, this is just a good model. So on the left-hand side here, you'll see it's the payer. We're looking at three payers. One is at $30 million in terms of annual revenue for the hospital. The second one is at 97. The third is at $35 million. And the blue is the current contract cycle. And the green is what we expect in terms of a three-year agreement. So the first payer, that contract was actually renegotiated with an effective date of 5/1/2020. And we did receive, that organization did receive 7%, 6%, and 5%. It's in a pretty strong market position. What you also should notice here is the flexibility in terms of the termination clauses. All three of these health plans with contracts with a health system have 120 days at any time. So even though you're in a cycle with a payer and you are receiving, let's say, a 2 or 3% annual rate increase, there's no reason why you can't give them notice, particularly based upon COVID-19, what you're experiencing, to increase your rates, because we do believe they're going to be highly profitable, continue to be highly profitable. Payer 2 here, and that contract is going to be renegotiated in the green effective 10/1/2020. We also specify the termination letter when that needs to go out. But again, this would be an opportunity if you have a payer that you need to renegotiate the next 12 months, is to really be more aggressive on your rates and your expectations, particularly in this COVID-19 environment. And payer 3, at the bottom, you can see the green bar. That's not until July 1, 2021. So it's a long way off in theory, but there's no reason you can't terminate that contract and renegotiate it, particularly if you've got low single-digit increases, because the payers are benefiting now from contracts that are multiple year, and those last 2 or 3 years are at low single digits. And we think you need to be at the table to renegotiate that as one of your tactics. So let's go on and slide 29 and provide you with some final thoughts and some takeaways here. And I'm just going to start by using these gray boxes as kind of a tier. So on the left-hand side, the first gray box, demonstrate unavoidable cost increases and financial challenges. I think you've heard a lot from myself and Purvi today around the cost increases. To the right of that is emphasize additional risks. Hospitals have to replace staff. They have to bring in registry. They have to bring in locums. So there's going to be overtime, double time, all kinds of cost increases. You're not going to be as efficient because your volumes are lower and because of all the things you've got to do to deal with COVID-19. In the middle here, on the left-hand side, is use this opportunity to expand your value-based strategy. I want to take a moment to talk about Blue Shield of California. So in most states, Blue Cross and Blue Shield are one entity, but in California, Blue Cross and Blue Shield operate as different companies. So they've been sending letters to providers about a transaction structure, a partnership, so to speak, from August 1, 2020 through December 31, 2021. And I want to use this as an example of what to be looking out for in terms of payers. So what Blue Shield of California is proposing is that they're going to provide you with a revenue every month, regardless of your volumes, based upon your previous volumes. So it's a cash flow strategy. In return for that, you as a hospital have to give up your trend increases for 20 and 21. So if you had a 5% increase in 20 and a 4% increase in 2021, you have to give up those increases in order to get an acceleration of cash from Blue Shield. And they're going to true up, still if you're submitting claims, they're going to true up what was the actual payment in terms of the cash acceleration versus the claim. So it's not any additional revenue, it's just a cash acceleration strategy. Well, what do you get in return for that? What they want to do, and this has to do with value-based partnerships, is they want a long-term agreement, 3 to 5 years. And I'm happy to send this document to anybody here that sends myself or Purvi an email, because it's really an interesting read. So what they want is a long-term partnership. And what's in that long-term partnership? Alternative payment models, DRGs with quality components, similar to CMS is one idea, capitated arrangements, or some risk-sharing structure. So clearly they want to continue to shift risk to providers. And part of that risk structure will include quality components, performance parameters. And so this is something that's, I think, of interest. Maybe some providers that are having cash flow issues, but you're giving up revenue increases, and you're also committing to some kind of a value-based partnership. So something to be aware of in the marketplace. The other item on this slide, the same tier here over the right, is obtain adequate reimbursement for telehealth. Again, there's a pretty good appendix here to give you guidance on telehealth services. Lock in those rates as soon as you can so that your telehealth rate is the same rate as an in-person rate. Don't wait for the payers to come up with their own national pricing strategy. Bottom left-hand side, be assertive with the payers. Continue to target rates based upon your market. We do believe in 2021, premiums will be at a minimum high single digits, because we believe the payers will argue that there's an unmet demand because so much care has been delayed. So in 2021, there's going to be more utilization. Therefore, they're going to increase premiums at least high single digits, and I wouldn't be surprised if we see double-digit increases from the payers on the premium side. And lastly, on the right-hand side, project forward and consider what service mix and care delivery model you're looking at. So when you look at what we typically do, is we agree to a trend for a certain year, say it's 7%, and then if you have the flexibility to allocate that 7% to inpatient, outpatient by services, put more dollars in those services that are going to be increasing, such as OB might be increasing in the marketplace, or cardiac services. So it creates an advantage for you if you can look towards the future and look at where your volume increases and put those additional dollars in the services that you believe are going to continue to increase year over year. So with that, I'm going to turn this back over to Rachel to begin the questions and discussion session.
Thank you. Before we move on to our questions, a reminder to our audience to please continue to enter your questions in the questions pane, and I'll ask as many questions on your behalf as time permits. With that in mind, our first question is, the payers seem to be avoiding negotiations using COVID as an excuse. How do I get to the table with them?
Yeah, so I'd be happy to give you my perspective on how to get to the table with the payers. So, a lot of organizations start out with kind of a voluntary discussion without a term on the table, and that's where the payers are going to avoid you the most, because there's nothing compelling to just try to get a rate increase. We do believe you're going to have to terminate contracts to renegotiate the contracts. That is the best strategy that we have seen. It compels both parties to work against a deadline. So if you haven't terminated to renegotiate, you certainly need to consider that strategy, because that's really the only way to compel a payer to sit down and negotiate rates, because you've got a contractual obligation where the contract is going to terminate and you'll be out of network, and the payers will not have you as a provider. So that is my advice. Purvi, would you like to comment on any other techniques to get the payers to the table?
Sure. I think I would just add on to what you had stated. I know that termination can sound pretty scary to providers, especially in a time where you're in a financial crisis. But oftentimes that termination is really a formality. There are select payers like United, for example, that do require what we call a soft termination. So this is really something that's formal. But what we've also found is that while it helps check the box on whatever is in your contract, it does, as Ken mentioned, hold payers to a certain deadline, because as you start to encroach upon that termination or renewal date, there are serious circumstances if you start to get to that termination date, and then members will have to start to be notified. So it definitely sets the timer for those discussions and prevents extensive delays.
Thank you. So the next question is, what should providers do with the competition from payer-sponsored third-party telemed services like Doctor On Demand?
Purvi, do you want to start with that one, and I'll add on to your comments?
Yeah, so I think with these third-party vendors, there are certainly separate arrangements that are put in place. You have to be careful about who's billing for those services. So if you as a provider are still billing for those services, you want to make sure that you still have some sort of a margin between what you're paying that third-party vendor and what you're getting reimbursed for. There are instances where those vendors are doing the billing, and so in that case, you have to be mindful of the contract that you have in place with those vendors. But in other instances, we're also seeing many providers that are developing their own platforms. And in these cases, you really need to be careful about making sure that you're monitoring and tracking costs and being even as transparent as possible to be able to share that with the payers to ensure that you're getting adequate reimbursement.
So I'd just like to add to that because we have a client example where they have Epic, but physicians weren't really trained properly for Epic, and it can be a little bit clunky from what we understand in terms of telehealth. And so the doctors in that system started using Teladoc, and it kind of eroded their platform. Now they're re-educating physicians on using Epic for telehealth. But in that marketplace, what they're concerned about is these national telehealth companies coming in and getting in between the relationship between the payers and the medical groups. So if you can't get access to your primary care or your specialist, then there could be a default mechanism whereby a third party on behalf of the health plan is intervening and talking to your patients, and it could be a remote physician. So I think medical groups are thinking about how can we add value with telehealth? How can we be the platform of choice, whether that's with the payers and also with the employers, because the concern is these third-party telehealth vendors may expand their scope, particularly with the health plans who are looking for lower costs and easier access, and they may make it in between the health plan and the physician group. So just be aware of that. And telehealth is going to be not only an important strategy today around COVID-19, but it's here to stay. And you need to think about the long-term strategic implications of your telehealth strategy with your physicians.
So while we're on telehealth, here's another question. Do you recommend that we seek lump sum upfront payments to cover the new costs related to telehealth, or should we negotiate our rates and get an extra % amount added into our base to account for those costs?
Purvi, you want to take the first shot at that one? See, I'm defaulting to Purvi.
So I think it's worth asking the payers for an upfront cost. Again, they really need to be partners in this situation. And, we've seen, just like with, pre-COVID, when value-based payment arrangements started to take shape, care management, we've talked about this, care management being a really key critical service. We did find that there are payers that are able to offer care management services in partnership with the provider. And so that all of that cost burden isn't necessarily on the providers. And so in a similar circumstance, I think it's worthwhile to have a conversation to talk about some of that upfront costs, especially, as Ken talked about, some of the acceleration in payments that's occurring around the country with the payers. They're looking to ensure that the providers succeed. And then I think if that doesn't go anywhere, then certainly building that into your reimbursement is a necessary strategy.
Yeah, I think one of the key thoughts here is on telehealth. We don't want payers or providers to create financial barriers to accessing telehealth in the future. I mean, right now there isn't really an out-of-pocket cost, but we don't know if there's going to be an out-of-pocket cost. There's not a big out-of-pocket cost. So we're hoping that in terms of what the patient's paying for access to health services in the future is a minimum out-of-pocket cost, because that access is really important. And from a health plan perspective, you could argue that the greater the access to primary care, the fewer ER visits, the fewer hospitalizations. So from a payer perspective, I think they would do well to continue to invest in telehealth, as a service and pay providers accordingly for the value of that service.
Thank you. And it appears that we have time for one more question. So going back to negotiations with payers, how does ECG recommend preparing for the CMS final rule requiring payer pricing and sharing that with consumers, and how that might impact negotiations?
So you're talking about the transparency rule?
Correct, yes.
Yeah, so we've talked to a lot of clients around the country, and they're very concerned about the transparency because some providers, hospitals, and physicians have very high contract rates with certain payers, and if payers are able to discern that my rates are much higher than somebody else in your portfolio, then there's going to be downward pressure on your pricing with that individual health plan. In reverse, it could work to your favor, where once that information becomes public, that you really don't want to drop whoever is your top payer in your portfolio down to a lower payment amount. So you've got to move your payers upward in terms of what they're paying for services. And this gets back to the parity argument, where whether it's on physician services at a percentage of Medicare or a hospital profitability margin, if you have a benchmark and the payers are paying you within a very similar range, when this transparency occurs, you're not going to have an argument because you're essentially requiring all commercial health plans on the physician side and the hospital side to pay you for the services at a similar rate. And you really have to look at yield then in terms of what is the health plan paying you on the hospital side as a percentage of billed charges versus other health plans. That's one way, and also profitability. I'd be concerned about health plans cherry picking and looking at a med surg rate, an ICU rate, an OB rate, because that's only part of the story. You've got to look at the whole contract in terms of what it's yielding, not just individual rates. But nobody is looking forward to this law being implemented because we feel it's going to create a tremendous more conflict between providers and payers. And not certain, I'm certainly, my opinion is I'm not certain of the value in terms of what the consumers are going to be able to discern from that and then make decisions on that price transparency. More to come, I think.
All right, thank you. Purvi, any additional thoughts?
No, nothing else. Thank you.
Well, thank you both. That concludes our formal program. Please note that if you asked a question we were unable to get to, we will follow up with you after the session. We would also like to make you aware of ECG's extensive library of thought leadership on COVID-19. Visit our website at www.ecgmc.com to learn more about these and other relevant topics. I would like to again thank all of you for attending today's presentation. If you have any additional questions or comments, please don't hesitate to contact one of us via the email information provided in the handouts. One final reminder, we would greatly appreciate it if you could take a moment to complete the electronic survey upon exiting today's program. As stated earlier, ECG will make a $5 donation to Doctors Without Borders for each survey submitted. Thank you, everyone, and have a good day.